This is the Barbell Therapy and Performance Podcast, where traditional healthcare is redefined to help listeners achieve peak performance, accelerate recovery, and elevate overall health. Hosted by Dr. Brett Scott, a doctor of physical therapy and national strength coach, this podcast explores the worlds of fitness, alternative medicine, and holistic health. Each episode uncovers innovative strategies and practical solutions for those seeking to enhance their quality of life when conventional methods fall short. It is our firm belief that every living thing has potential, and it is our mission to help you find that potential.
All right, everybody, welcome back to the Barbell Therapy Podcast. I'm your host, Dr. Brett Scott, and with me here today is Laura Brown. She is the owner of Sapphire Women's Health in Westford, Massachusetts. She's a women's health nurse practitioner, and she is certified through the Menopause Society as a certified practitioner there, and is also a wellness coach. So there's lots of different things that Laura practices. And Laura, tell us a little bit about the different things you practice. So I know there's a lot we're talking about today. So today we're going to be talking all about Ozempic and GLP-1 inhibitors, but you also do some things with hormonal health and things for women as well, right?
Yeah, so my focus really is on perimenopause and menopause. So I do a lot of the hormone therapy. A lot of people call it HRT, so hormone replacement therapy. But we do hormone therapy, and I do a lot of wellness coaching with all of my patients. But I also have somewhat recently added medically supervised weight loss to all of my services. So I definitely employ the use of the GLP-1s in that program.
Yeah, so that's kind of what we want to talk about today, because we've already had a lot of people on the podcast about menopause. We see a lot of women that are going through it, struggling with weight loss.
Yeah,
it's a big trending topic these days. So we don't need to go too much down that. So if you guys are curious about that, go listen to some of my previous podcasts on menopause. But Ozempic, GLP-1 inhibitors, Wegovy, all those. They're kind of all the rage right now. All the celebrities are using it. People can't even get their hands on it. And it works for weight loss and fat loss, for sure. But, people kind of tout it as this miracle drug. But do you think it is a miracle drug? And what do you think about that?
I think it's a really useful tool. I struggle with miracle drug because I think anytime that there's things like this, it seems like a quick fix, or, I think there's a lot of sort of stigma around it of like, you're just doing it the easy way sort of thing. And I do think that there are probably a number of people who are on it who don't really need it, but there are also a lot of people who really very much benefit from it. And I think if it's done right, it can launch people into a new sense of wellness, rather than sort of feeling the frustration of trying all these different ways to lose weight without success or without being able to keep it off.
Mm-hmm. So how does the drug work as far as, its pharmacology and working in simpleton's terms for people to understand what it's doing and how it's working?
So we have really good data on how it works in the gut, and it actually just slows down our digestion. So that can certainly lead to some side effects, which I'm sure we'll get to later. But that's the way that we know it works really well. And it works on glucose molecules. But then in the brain, it's really interesting. We know it works in the satiety center, so the fullness center, but we don't know exactly how. And so they are studying it for the use of other things like alcoholism and addiction. And I heard somewhere that they're also studying it for certain mental illnesses like bipolar disorder and schizophrenia. I know they've been having a lot of luck with the alcoholism and addiction, and even sex addiction. So I think it's been on the market for about 20 years, but it just hasn't been sort of widely used for weight loss. It started out as an anti-diabetic, and then they were just noticing that the patients who were having great success with it were also losing weight. And that's how it kind of came out into the rest of the world. But there's a lot we know about it and a lot more that we don't know.
Yeah. And so as far as the weight loss goes, isn't it really kind of just like, as people say, like quiets the food noise? Just making it so you're not hungry or you don't have an appetite for food. And you go on that a little bit.
Yeah, so I have, I have a number of patients who are on it, specifically semaglutide, which is a compounded version of Ozempic or Wegovy, and they have that to varying degrees. So some people feel like I'm just not thinking about food all the time like I used to, or I didn't even realize how much I was thinking about food. And then there are other people who are really feeling it more as an appetite suppressant. So they're like, yeah, I'm just not that hungry. And with those people, we have to work on making sure that they are eating and hydrating. But I think for the people who it quiets that food noise, they're able to re-examine their thoughts and sort of their habits around food in a way that they aren't able to when there's this constant sort of chatter about like, well, what are you going to eat next? And how dare you eat your kids' Halloween candy? And sort of just this like almost constant ticker in the background of like food noise, positive or negative, right? Like, are you getting enough protein in your diet? Are you drinking enough water? But also like some judgment in there too of like, you slob, I can't believe you would eat 3 dinner rolls, those sorts of things.
Mm-hmm. And so you mentioned too, there's people that are taking it for the right reasons and people that are taking it for the wrong reason, or people that it can really benefit. So who are the people that it's really going to benefit in the right way?
Yeah. So obviously, the diabetics, that's who it was originally intended for. And it's doing really remarkable things for a lot of diabetic patients. It's bringing down a lot of their biomarkers, and we're seeing even remission in some cases. And I will caveat this, it is indicated for type 2 diabetics, not for type 1. That doesn't mean we don't have some type 1 diabetics on it, but they have to be monitored very, very carefully because of their sort of molecular makeup. But I think the people who are constantly yo-yo dieting and just haven't been able to find something that is sustainable, because over 90% of diets just aren't sustainable in the long term. I think restriction in general just isn't sustainable in the long term. And so I think for those people who are, definitely obese and overweight and who have metabolic disease markers like increased A1C, which is how we determine if you're diabetic or not, or elevated cholesterol levels, impaired fasting glucose, insulin sensitivity issues, those people are seeing pretty remarkable improvements in those markers. And by doing those improvements, we're seeing a reduction in their risk of developing type 2 diabetes and cardiovascular disease. So it's a beautiful tool for a lot of people. But I think it's the people who go on it because they just, they are sometimes taking the easy way out for some people, or it's just like the last 5 pounds or something like that, that can be stubborn, and certainly I think impacts people's self-image and confidence. But I think, it drives me nuts when I hear someone say like, oh, I'm just going to go on it for 5 pounds before vacation. Like, that's not a good reason to go on this medication. And I think maybe that's just a time for some introspection about your habits and about your self-confidence too.
Mm-hmm. Now, for these people that it's, it is doing the right thing for them as far as from a physiological perspective or biomarkers, could the same thing not happen if this person, say we put them in a lab test and just threw them in a box all day and just fed them the right foods and they didn't have to make any decisions about it? Could we see those same changes without the drug?
Potentially.
Okay. So
it's not a satisfying answer, I know that, but
yeah, well, that's kind of my thing again about that. Part of why I'm against the drug. Like, I'm not for nor against it, but it's just there's so many factors in our lifestyle and what's marketed to us now. And are you familiar with Casey and Callie Means at all? Like, have you heard of them?
I sure am. I'm taking a boot camp with her right now, actually.
Okay. So like all the stuff she's brought up is like remarkable as far as like, yeah, we have all the stuff with food engineering and processed foods and pesticides and seed oils and all these things that are in our diet. And like, I think she brought up, I think the stat was 50 years ago, 3% of our population was overweight. Now, 50 years later, 50% of the population is overweight. Like, what changed? So is it really that we need this drug? Because now they're trying to get like 6-year-olds, I think, cleared by the FDA to take it because they came out and said obesity is a genetic problem, which maybe we're inheriting some bad genes from our parents now that we're changing our genes with all this crap in our environment. But
right.
Like, yeah, I feel like most people, if they could change their diet and do a lot of things, like we could do it without the drug.
I totally agree. I think there's definitely there's a lot of re-education we need to do of our general population. We need a lot of people on board. Like, we need to be, I mean, we've messed up our food in a lot of ways, and we've messed up a lot of things in our lives, and our exposures to all sorts of things are probably impacting us, at least on a cellular level, if not on a genetic level. I think, yes, there are definitely people who can do this if they, if they've got all the right information and the access to all of that. I did struggle for a while about whether or not I wanted to add this to my services. And I did a lot of research, and I think there was still sort of that idea in my head of like, it's the easy way out, but as someone who's also struggled with weight and tried various diets and psychology and all sorts of things, I get how incredibly frustrating it can be, especially I think for women in perimenopause who are doing all of the right things, and they're still seeing not just the scale go up, but their A1C and their cholesterol. And they're like, I don't know, for some of these people, it's like, I don't know what else I could possibly be doing, because all I do is exercise and eat protein and sleep. And so that, I think there's some frustration there, but for the more general population, I think I think a lot of times it comes down to psychology. And so for me, deciding to go into this was because I saw a lot of people doing it the wrong way. They were not teaching these patients about how to make lasting lifestyle changes so that if and when they come off of this medication, they're not gaining it all back. And while they're on it, they're not losing muscle mass in, crazy amounts. And so I felt like I had tools at my disposal, my knowledge in health and some, nutrition and fitness. And then certainly with the coaching of like, how can we make these changes lasting and empower people? And sometimes you just need that little motivational, like, oh, look at that number's going down. Or I have an in-body composition scanner in my office. And I think that's an excellent tool because it just gives us such better data than just a number on a scale or just BMI, which is a complete garbage made up measurement anyway. And I've really seen the power of like when people are seeing those changes, how much that can motivate them to continue making more changes.
Mm-hmm, for sure. But going back to what you said too, it's like a lot of this comes down to behaviors people have.
Yes.
And the drug is just blunting the response of us wanting to have those behaviors. So that's kind of what I'm kind of curious of what you're seeing on your end of if people do come off this, mm-hmm. do a lot of them stick to the behaviors they have, or does that food noise stay more silenced, or people coming off the drug and it's magnified and they're, an addict that goes off the rails again?
So to be fair, I started this in August, so I don't have anybody coming off of it yet. Okay. But my goal really, I don't want my patients to have to be on this for life. I mean, it's a crappy business model, but I don't want them to have to be on this. And so I kind of look at this as my gateway into behaviors. So we have, a lot of people know that they're supposed to be working out, and hopefully, especially women are now getting the message that part of that really needs to include the resistance training and the weight bearing exercises. And they know that they're supposed to be getting fiber and fruits and vegetables, but they're just having a really hard time making the right choices because of habituated habits, really, just of like, I'm an emotional eater, and not knowing how to self-soothe in more productive ways for themselves. So the way I put it with my clients is that we're taking one thing off of your plate. And so we're just not going to even have to contend with the food noise for a couple of months or, however long we're on this, and use that as an opportunity to start really implementing these better habits. And that's focusing on hydration. It's really making sure that we're getting excellent sleep, because when we get those two things, we're going to decrease the inflammation. When your body thinks that you're constantly in danger, it's never going to release any of that stuff, because it's always wondering, well, all right, if we're fleeing our homes, we don't know when the next meal is coming, so we can't let go of any of this. So we work on a lot of that. We work on the stress reduction and true, sort of coping techniques that are going to serve them to be the person that they want to be. And we start bringing in the nutrition and the protein and the fiber and then the fitness part of it. And I try to have them sort of pick one thing every week or so that they're really going to hone in on. And my point with it all is that we get them to a good place where they've just got those things on lock. And then we start decreasing the medications. And then all they have to contend with is the food noise. But we've done the coaching so that now they're in a place they can coach themselves and they can go, I know what my brain is doing. And I know the story it's offering me. And I'm choosing not to be the person who goes to the carb cabinet after my kids go to bed.
Mm-hmm. And you mentioned this with menopause, perimenopause. Mm-hmm. For those women, a lot of it too, and I think we're starting to get better about it, but hormones are a big issue in that demographic of women. And so I think it's still taboo to be on HRT or talk about being on HRT for a lot of women. Not all of them, but a fair amount of them. So, but this Ozempic, Wegovy, they're all mainstream now. So it's like, so many people are going to this as probably a solution when really, do you think if a lot of people just fixed up their hormone profile and maybe started doing HRT, that's actually probably healthier with less side effects and less risks than the GLP-1 inhibitors, they do better?
Yeah. So I think they're supportive of each other in a lot of ways, but I do think, and what I would say is, and maybe it's just the lens that I'm coming from, and my patients are extremely well educated. And by the time they're coming to see me, they've already had several clinicians tell them, no, they can't be on this because we're really fighting against some really old, crappy information that has scared everyone about hormones. But from what I'm seeing is that women are understanding a lot better that HRT is an excellent choice and is preventative for a lot of things. So we know it's actually estrogen is approved by the FDA for the prevention of osteoporosis. So we know that it's preventative for that, and we have really good data. We haven't done the official studies, but really good data that shows that it's also very likely preventative for cardiovascular disease, which is the number one killer of women in this country, and then also preventative for dementia. And I do think, given some more time and more research, we're going to see it approved for those uses and used for those uses of really prevention. What happens in perimenopause as we're losing estrogen is we actually don't fully lose estrogen. We just sort of lose the one that's sort of dominant in our fertile years. And it changes over to something called estrone, which is a different kind of estrogen. And that one just really loves fat cells. So it makes it much more difficult to lose weight, even doing all the things that you always used to do that worked no problem. It makes it much more stubborn fat. And it also tends to redistribute the fat from where we used to carry extra pounds, maybe on our butt or our thighs or our breasts, and it puts it into the belly area. And I call it the menopause donut because people are like, why can't I button my jeans? I weigh the exact same, but it's just all in a different place now. So I do think when we give back some of those hormones, it makes it just a little bit easier to lose the weight again. But I love talking to women about testosterone and how that can really help with body recomposition, right? So it's going to be supportive of building that muscle mass. And we know that when we have more muscle, we're going to be leaner and be able to lose fat cells a lot easier too. So I think they work well in tandem with each other. But at this point, no HRT, whether that's estrogen or testosterone, is sort of indicated for weight loss.
Yeah, I mean, but it's also why this is some of the stuff with like what goes on in the media, in the news, and in government and politics right now is it not indicated just because there's no money behind it, because they're not a patented drug that no pharmaceutical company can make money off of?
I mean, I think it's a really complicated thing. I think we're overcoming 20 years of the Women's Health Initiative that came out and said that estrogen causes breast cancer and stroke and heart attack, and it doesn't do those things. It's really safe and, again, preventative for a lot of those things. So we're overcoming. It's not just our patients. That's the problem, is that there were 2 generations of clinicians who had zero menopause training, or what they did receive was that estrogen causes breast cancer. And everyone knows the Hippocratic Oath, first do no harm. So of course, doctors are thinking that they're protecting their patients, but instead they're living in these dark ages and they're not up to date. They're not practicing to this newer research, we have great data from before the Women's Health Initiative and really great data after that shows how safe this stuff is. And that like, yeah, this is why I opened my own practice, because I was shackled by sort of traditional medicine and I wasn't able to practice in a way that is more up to date. And it was so frustrating to time and again have to tell my patients no when we both knew better. And it was just outdated information that clinicians are living by. And so I think, it's sort of the same thing with, I think we're seeing a lot more functional medicine coming out and talking about toxin exposure and processed foods and those sorts of things. I think they lend to each other really well, because it's just like, of course, why wouldn't we look at the root cause? Why wouldn't we try to solve it from the bottom up rather than just keeping to put on more bandages? That all of these, pharmacologic agents come with their own set of side effects. And then are we just like putting more bandages on top of the side effects? So it's an area that gets me really fired up. But yeah. It's overcoming knowledge deficits. I think that's what it is.
Yeah. Cause I've seen with a lot of men that have low testosterone, they go on testosterone. It's like all of a sudden they can lose weight, like it melts off of them. Mm-hmm. So I don't know if the similar could be true for women. And, is there an ill side effect too, or negative side effect of, or can we theorize that if a woman is low estrogen, menopausal, perimenopausal, whichever, and then decides to go on one of these weight loss medications, but we haven't fixed the hormonal profile, and we know with the GLP-1s, there's issues with the increased loss of lean muscle tissue and things like that. Yeah. Could we be making some problems worse?
Yeah, for sure. And I think especially when women are going to, local or online clinics, honestly, that aren't doing this background information and warning them, right? Because I'm just seeing that all the time of these people who are just getting these meds handed to them and no one's telling them about the loss of lean muscle mass. And no one's telling them about how to lift weights or, other ways that they can be improving. So I think it's not necessarily like no one should get these. It's just that people should get them with the right information. And a lot of people are not right now. I think that's the problem.
Mm-hmm. Yeah. So let's talk about that. Is what things do people need to know about these drugs before they get on them? Because, some of the things I've seen, heard, read about is pancreatic shutdown. Mm-hmm. So pancreatitis, which is inflammation of your pancreas, visual changes, low blood sugar, kidney problems, gallbladder problems, thyroid tumors, and even cancer. So there's a box warning about thyroid cancer and tumors. Mm-hmm. Mm-hmm.
That is the box warning about the medullary thyroid cancer and multiple endocrine neoplasia is it was seen in mice that was tested on. We haven't actually seen it in humans, but that doesn't mean we wouldn't if we didn't, if we had larger populations that were receiving this drug. So, for those patients who have a personal or family history, that's not something I would give them. And so I think if you're interested in getting these agents, just being smart about who you're getting it from, and whoever you are getting it from should be taking a full health history, right? So asking about your pancreas, asking about gallbladder disease, asking about family history as well. And like, what's your previous weight loss attempts been like? What made it hard for you to lose weight in the past? What are your motivations right now? Like a really holistic approach to it. And if they're not asking about these things and they're not doing some baseline labs, I think that is not the right person to get those medications from, because they're not going to make sure that you're safe while you're on them.
Mm-hmm. And now, giving someone a drug that can cause cancer, this is one of many drugs that has all kinds of side effects to it, right? But mm-hmm. Mm-hmm. Obesity in and of itself can cause cancer. Mm-hmm. Now, the thing is that I don't know, and I don't know if you would know, but is it the fact that someone's obese that they have cancer? Because, you could be obese and eat, grass-fed, grass-finished foods and organic and have no pesticides, and you can still eat yourself into obesity. It's going to be much harder than someone that's eating. So is it, the toxic load from the obese people that are eating processed foods and, all kinds of different fats and things?
I don't know the answer to that, but I
Yeah.
think there's, it seems to be from what I have seen and researched is that obesity itself is a risk factor. I don't know that they've parsed this out, right? So like, here's the problem is that traditional medicine is not necessarily looking at your processed food intake.
Mm-hmm.
And so I don't know that that's been specifically researched.
Yeah, because that was another thing like a while ago when it came out that red meat was cancerous or carcinogenic. Yeah. I learned in one of the main studies they looked at was just daily meat consumption. I think like something like 30% of daily meat consumption comes from McDonald's. That's included in that study. Which like you have to look at how many of those people drink soda every day and smoke and you know are not going to the
moving
gym,
their bodies,
exercising. Right. So.
And their stress levels and what are they sleeping and how is their vitamin D? You know, I mean, there's so many factors that we're not taking into consideration, but I'm sorry, I interrupted.
Yeah, no, you're good. But that being said, are we seeing other risk factors come down because of Ozempic?
Yeah, we're seeing reductions in blood pressure, A1C. I mean, all the biomarkers, we're really seeing improvements in a lot of them for a lot of people. I had a patient who came to me for both HRT and weight loss, and we did her baseline labs, and she'd been previously put on Metformin for prediabetes by her PCP, and then they just sort of took her off of it, and I'm not clear why, but she really wasn't seeing a reduction in her A1C at all. And she's been on it for 8 weeks, and she went from a 6.2, which is very close to the diabetic range, down to a 5.6, which is below pre-diabetic range. And she had already been fairly active and a fairly clean eater, but she also has some hereditary issues. And, you know, there's certainly some question about whether ethnicity plays into certain biomarkers. But yeah, so I mean, we saw a really good improvement with her, and she's feeling really good. And I think actually she's feeling really good because I put her on progesterone, so she's getting a full night of sleep. And that's also, she has endometriosis, which is a chronic inflammatory state. And by putting her on the progesterone as well, that's reducing the flow and duration of her periods as well as her cramping. And so she's not anemic either, right? Like if you have more iron, you're gonna feel a lot better. You're gonna have a lot more energy. So I do think like these things aren't necessarily mutually exclusive, but they can work really, really well together. And so I'm seeing it. I'm seeing how well all of these things can work together and separately.
Yeah. And so the other piece here too is a lot of the talk has been that once you go on this, you have to be on it for life. Mm-hmm. But you're talking like that's not the case or doesn't need to be the case. So what's going on here?
Yeah. I mean, I think again, it's that like, are we educating people? Are we telling them like, this is what's going to happen, or these are the potential effects of when you come off of it? And are we just completely stopping them one day, or are we gradually decreasing that dose? Like, what is that looking like? And so I think, again, it's unfortunately in traditional medicine, doctors have 10-minute visits. There's not enough time to talk to their patients about all of what they should be. You know, we can sit there and tell them, these are the things you should be doing. Goodbye, right? Like that's all we have time for. We don't have time for an actual conversation about like, okay, let's dig in. So you don't like lifting weights. What can we do that is a joyful way to move your body so that you're going to stick with it, right? Like I have never been someone who loves going for a run. I would do it sometimes because I would train for a 5K or something like that. But as soon as the 5K was over, I had a great excuse not to go hit the pavement again. And so it wasn't until I found bar classes that I was able to find something that I can stick with. And now that's something that's really important to me and has been for 6 years now, right? But like I had to figure that out. And so it is like I'm coaching my patients, like figure out exercise that is not a punishment, right? Like it should be, you should be looking at it. And this is part of the thought work too, is not just like finding the thing that's not a punishment, but also looking at exercise as a privilege that you get to move your body and as a way to take care of yourself, you know, down the road. If you do the work now, you're going to age so much better. And I think especially for women, we live longer than men, but we tend to live much more of our life in poor health. And part of that is because we are caregivers by and large to many other people, and we are constantly putting other people first, and then never really learned how to take care of ourselves. Like my generation, we grew up in diet culture, which was just like, just make yourself small. don't eat carbs. That was the only diet advice we got, that carbs are evil, and cardio. That was it. Right? Like, we weren't told, like, no, exercise should be a beautiful thing. You should be building muscles. You should be just as strong as your future partner. Like, none of that message was given to us.
Mm-hmm. So what is the difference though with people thinking they need to be on, why are people getting told they need to be on this for life?
I think the diabetics, that's probably more true. But I think the reason people are hearing that is because what we're seeing is when people come off of it who haven't been told how to make changes, they haven't made changes, right? So like, they're going to go right back to what they had been doing before they were on the drug. And unfortunately, they're gaining back weight, but all they're gaining back is fat. They're not gaining back that muscle. So I think a lot of people are like, well, that's just it. I'm signing up for life, because the second I come off of it, it's all going to come back and I'm just going to be right back where I was. But if we actually coach people and teach them how to move their bodies and fuel their bodies and make sure that they're really caring for themselves holistically, then I think there is a great opportunity for many of these patients to come off of it safely and with success.
And there's other doctors that are doing this successfully that you know of, that are getting people off of the drug?
I don't know of them yet.
Okay.
But I think right now what the media is telling everyone is you got to be on this for life. And I think a lot of that is, not to sound conspiratorial, but big pharma, right? Like, they're going to make money because everyone wants them. And if you think that you're going to be on this for life and that's what you're signing up for, then you're like, great, that's my copay for life. That's it. I'm fine with that.
Yeah. And are there other issues we see with coming off of it though, as far as like, or anything we can theorize saying, my pancreas isn't going to work the same because it hasn't had to work because the glycemic load isn't there? Like, what?
Yeah, I mean, I think there's a lot of things that we, and if you're gaining back the weight and again, more of it is fat, then I think we're going to absolutely see increases in type 2 diabetes, in cardiovascular disease, blood pressure. Like, I think all those biomarkers are going to, skyrocket back up. My concern right now, whether people are staying on it or coming off of it, is I do think we're going to see a lot more osteoporosis because no one is telling these people that you need to build up your bone strength. So that's where I think that's a great intervention point for my patients, is like, listen, you're heading into menopause. You're already going to have weaker bones. We need to be doing something about that right now. And if you're losing muscle mass, that is going to make it worse. Sarcopenia is that decrease in muscle mass, and sarcopenia and osteopenia play with each other, unfortunately, in really negative ways. So the more sarcopenic you are, the more osteoporotic you become, and vice versa. The good thing is, if you improve your bone health, you're going to improve your muscle health. And if you improve your muscle health, you're going to improve your bone health. Yeah. So they're easy interventions.
So what you're saying too is that these drugs don't cause osteopenia or porosis, not breaking down bone, but when you're losing muscle, you can't load bone as much, so you're going to indirectly be losing bone mass. So Interesting. Okay. And then the other thing is, are there studies they have on like tapering protocols or anything like that? Like, because that's the other thing is most people probably get to a point where they're starting to plateau at some point.
Yep.
And then
and go ahead.
And then it becomes, so do people come off? Do they stay on? Like, what? And then, are there study designs showing like this is good, this is bad? Or it seems like it's kind of the Wild West out here right now of every doctor's kind of trying and doing different things and seeing what sticks.
Yeah, I think that's right. I think it is kind of the Wild West. I'm not aware of studies on how to taper down because, again, like, these were designed for diabetic patients. And we think of diabetes, even if it goes into remission, as a lifelong illness. And so the idea for the original indication for these medications was for diabetics who were never going to come off of these. So why even study coming off of them, right? Like, what's the point? You just know that you're going to be on them. I think most of us who are prescribing them do not feel comfortable with like a dead stop unless there's, something going on with, major emergency, like a pancreatitis or gallbladder issues, something like that, or pregnancy. So most of us, I don't think, are comfortable with just like, oh, you're at 40 units a week, let's just stop it now that you're at goal weight. I think most of us would think, all right, let's taper back down. And I do know that, and again, I don't think this is studied, but I do know there are a lot of people who are microdosing it. So using just like 3 units a week, something like that. I think even Peter Attia has talked about microdosing the GLP-1s. And he's a big voice in these sorts of spaces. So it's interesting. And I think we need a lot more studies. And I think there's a lot of people who are going by anecdotal stuff, which is okay. It's just not sound science. And I think it's just, again, making sure that whoever you choose to prescribe this is going to be like an actual advocate for you, and making sure that you're being safe. First and foremost, that you're safe on these meds, but then also really talking to you about how to intervene in other ways that are going to make your lifespan and your health span what you want it to be.
Yeah. And so, what's the deal with Peter Attia and microdosing? Because Peter Attia...
I don't know. I heard, it's like, I've heard from a couple of people that he microdoses it, but maybe that's just a nasty rumor people are spreading and I'm just making it worse.
Interesting. I'll have to look into that one a little bit more.
Yeah.
What else do we have here? Are there, or for diabetics, I guess, is this drug better than things like metformin for them?
I think still the sort of stepping stone is to start with metformin. That comes with a lot of side effects too. And we use metformin not just for diabetics, but for PCOS, and sometimes for other things as well. I think, again, like sort of the protocols right now are start there. And if you're not having success or you've maxed out the dose, then moving on to some other meds. There's a lot of anti-diabetic agents out there, and there are some oral ones. I think, if I'm not mistaken, Ribelsis is an oral version of semaglutide, but I might have made that one up. So there's lots of options. And I think a lot of people don't love the idea, and especially diabetics who might be, pricking themselves several times a day anyway for blood sugar checking and monitoring. They might not love the idea of putting yet another needle in, right? So it might feel easier to do a daily pill or twice daily pill than to add another needle. I had been in internal medicine for a few years before I got into OBGYN. So I did manage some diabetics, and this was not really out on the market so much, or at least not widely. And so we did start with the metformins, but also we didn't have the CGMs like we do now. And so I think that is making, those are becoming pretty widespread as well. And there are some that are over the counter, and people are using that data to make some changes or to just sort of see where they're at. But I think,
even in the fitness field of people that are non-diabetics that are perfectly healthy are starting to use CGMs just to kind of see what they can do to get their diet and their blood sugars and things right, so they're not spiking and maybe losing weight from that.
And I have a patient who's a big time runner, and she's been using a CGM for a couple of months, and she found out like she can't eat green grapes. They totally spike her blood sugar. And if she eats peas, they spike her blood sugar, but she can eat that with an avocado, and that fat kind of helps minimize the spikes. But also she's changed how she's fueling on her long runs, right? She used to have those big goo packs, like a whole bunch of them when she'd go out for her marathon runs, and she's changed it. She, now she's eating like a protein waffle with some peanut butter, and that's doing it for her. And that's, she feels better. I also have her on testosterone, and I've replaced her other hormones. And so, we're working in a really, but she's also someone who's very, very in tune with her body and kind of, wanting to optimize everything. She's not my typical, and she's not on the GLPs, but she's not my typical kind of patient, I would say. But it's just, I'm seeing it sort of from all angles. It's really interesting.
She sounds like,
I feel like you fitness nerds like just love the data. Anytime you can get data.
Most of us, yeah. I mean, there's something to be said for it. So like, in our field, like the Whoop is really big, or the Aura rings, and sleep data, or cardiac data, all that stuff. And then, powerlifting is really like it's a pretty big nerd sport. Like, there's a lot of scientists, engineers that get into it because it's just like all these little mini experiments you can run on yourself and tracking percentages and progress. And some people get like, I'm not that much into data like some people are, but I have a lot of people that come to me, and even like if I get someone and I know they're a powerlifter or whatever, like I can look at their intake and be like, "You're an engineer, aren't you?" And they're like, "How did you know?" I'm like, "Just the way you detailed everything out here, I could tell."
Yeah.
You're like a powerlifting engineering nerd. So it's always fun.
Clark Kent, right?
Yeah. And so what things do people really need to know? Or actually, before I ask that, so you talked about the study designs of this drug was originally developed for diabetics. Have there been studies on using it for weight loss, or are we just using it off label? Like, how is this working?
Yeah, it's off label. Mm-hmm. I think they are working, and they may have already gotten the indication for treatment of obesity, probably for Ozempic, but any of the compounded meds, those are technically off label. So I do compounding because it just tends to be more accessible. Plus, when I first started offering this, there's quite a shortage of the branded meds, and I did not feel okay, prescribing these medications for people who didn't quote unquote need them. And taking that supply away from people who actually need them. So that's part of why I do that. And then also because with the branded ones, most of them are in the pens. And so they have very set dosages. But with the compounded medications, you draw them up from a vial. And so we have a little bit more wiggle room. So like starting dose is 10 units, but some people are a little bit nervous, or they tend towards chronic constipation. And so they don't want to go whole hog right off the bat. And so we can just, maybe we start with 5, and maybe that's enough for them, right? So like anytime that you can minimize side effects and, keep a dose lower, but keep it effective, I think that's always a great option. And then similarly, when it's time to increase the dose, some people are really nervous about going from 10 to 20. And so maybe we try 12 or we try 15, and that gives us a little more flexibility. But yeah, I think most people are using it off label.
Mm-hmm. But with that being an off label use, like there's really no studies behind it right?
So that's what's tricky. So off-label, just when someone wants to get a drug approved by the FDA, they basically have to choose like one kind of population, one kind of ailment, disease, what have you, to get it sort of approved for. Yeah. But oftentimes we see, and it's specifically in this case, right? So we use it for an anti-diabetic agent, but we are seeing a ton of these patients have pretty significant weight loss. And so we just sort of extrapolated, and the FDA is like, okay, it's not what it's approved for, but like, cool, you have enough data that we're not going to say don't use it for this, essentially. It's sort of like testosterone for women. It's really only approved for the treatment of hypoactive sexual desire disorder, which is just like fancy medical speak for low libido, but only for the postmenopausal population. But I use it for my premenopausal women, and I use it for people who don't have issues with their libido. They just need it for other things. So, but don't tell people that. I think I'm not supposed to tell people.
Okay. Will do. And so why, I mean, yes, these drugs have been around for a while because it's actually a peptide, isn't it?
Mm-hmm.
Why did it become so popular like in the past 2 years or so?
Probably media. I mean, I think too, it's interesting because I feel like there is always sort of this like, there's stigma around weight. Like we live in a fat phobic culture. And so a lot of people who are overweight or obese are, discriminated against in a lot of ways. And then, but what's interesting is that they're like so praised for when they do lose weight. And I think for a really long time, people would brag about, Oprah and Weight Watchers, right? Like, it's like, oh, this is what I did. And it seems accessible to people. And so I think it's interesting now because I think more and more celebrities are coming out and saying, oh yeah, I'm using Ozempic, I'm using, like Kelly Clarkson. And so it's almost giving permission, I think, in a lot of ways, or like, a lot of people see themselves reflected in weight struggles. And so to hear that there's this miracle drug, that they don't have to try that hard, I think there is some of that instant gratification of what our culture and society kind of is into anyway. But I think also for the people who have struggled with weight for their whole lives, it's like, okay, well, here's one thing I haven't tried yet. Let me, I've done Weight Watchers, I've done Noom, I've done keto, I've done juice cleanses, I've tried intermittent fasting, and some of it might have worked for a little while, but it's not sticking. So I think it's just one more option. But yeah, I don't know why in particular this seems to be So maybe because it's so much safer than like the last weight loss craze of fen-phen, which like killed people. I don't know. I'm not sure. I think it's just, there's a lot of the instant gratification. Yeah. Mm-hmm.
See,
Fen-phen. Yeah.
I've heard interesting things about that though, too, that was kind of blown out of proportion from what it was.
Probably.
Yeah.
Because that's what we do.
Yeah. And it was like,
but like, we're not really seeing people die from Ozempic, and not that everyone who tried fen-phen was dying, but like it was killing some people.
Yeah.
And again, they were probably the ones who went to clinicians who were not doing enough of a background check essentially on them and getting their full health history before they prescribed it. So
I'll tell you,
whose fault is it really?
back in college when I was trying to be a bodybuilder, I literally you could get it at a supplement store. It was like the quiet under the counter, like they don't tell you they have them, but everyone knows.
I know what you got back there. Yeah.
It was just like drinking 12 coffees a day for a month at a time. So definitely if you had cardiac issues, I would not suggest fen-phen.
No, yeah.
But the other thing here too, that it recently has popped up in my thing multiple times, is Ozempic face.
Like the sunken cheekbones. Is that what you're talking about?
Sunken cheekbones or sunken eyes. Yeah. And you know, I saw something about it. I was like, you know, there almost is something to when like now you see someone like with like a rapid weight loss, you're like, yeah, you can do it without it, but it's almost like there almost is a look that people have sometimes when they're doing it. So what? Yeah,
and I think now it's easy to blame it on that Ozempic, but like it probably has been a face of rapid weight losers in the past. It's just that like we couldn't so easily be like Ozempic, that's what that was.
Yeah, I don't know, because the only thing I can think of is really like if you're losing muscle, like you still have muscles in your face.
Yeah.
So are you losing those? Because the big thing is, and I could be wrong, tell me if I'm wrong with this, but if I were to lose, so like even I might be a good example of this. Last year, I lost 40 pounds in 6 months. I had a parasitic gut infection, whatever, came back from that. But I was in a pretty significant caloric deficit. I definitely lost a significant amount of muscle mass. But I just I was on a roll. It was the first time in years I'd been able to lose weight because I figured out what was going on. I was like, I was just excited to make progress and get towards my goal. So I lost muscle mass and like my t-shirts were like floating on me, whatever. And my face definitely thinned out a lot. But if I was on Ozempic, would that muscle mass happen more rapidly because of the drug itself, which is what it seems like is the...
Yeah, I think so. And I think that, you know, I mean, starvation diets too, like you're going to, no matter how you're losing weight, some of it is going to be your muscle mass. Right. And I think, you know, in cases like yours, where you're coming into that weight loss arena with a lot of muscle, it's probably your bigger muscles that are going to kind of go first, right? Like you have more stores there versus like the cheekbone muscles and those sorts of things. But eventually, like it's going to come a little bit from everywhere. It's not just like, okay, we're just going to take from the left bicep first, you know, and then like go from there.
But in the case of Ozempic, is that loss of muscle accelerated more than the person that's just losing weight naturally? I would assume
probably
so, based on what I've heard. So
yeah,
is there what should people be doing to prevent Ozempic face? Besides Botox and fillers.
God, oh, please don't do that. I mean, if that's your choice, go for it. But I think it's making sure that you're hydrated. No one is hydrated enough. It's so funny to me when I tell people just like track your hydration for a couple of days, and I have them use this app called Water Llama, and people are like, "Oh my God, I really thought I was drinking enough water," and I'm like, "Yeah, I know." Like we all think we are, right? But that's so important I mean, that in and of itself is going to keep us fuller longer, right? And then fiber, and most of it should be coming from fresh fruits and vegetables and whole grains, and but a lot of people do need to supplement that to get it's recommended about 25 grams a day. And then protein. A lot of people, and I think especially women, were just not taught how to eat appropriately. They were just, like I said earlier, they were just basically told that carbs are bad. They probably didn't learn that fruit is carbs, right? Like, and so they were just eating salads with chicken. That's what you had all the time. And I mean, I was thinking about this too. I was like, remember the Special K diet? Like, do you remember that? It was just like, eat like Special K for like 4 meals a day and you'll lose weight. And like, yeah, of course you will, but you're going to be malnourished too, right? So it's also like, you want to be tracking. When I work with my patients, I talk about fiber, I talk about water, and I talk about protein. And I'm like, those are the only things I want you to focus on, because if we get into all the little nitty gritty stuff right now, it's going to be too much. Your brain is going to say, nope, too many changes. We're just not going to do it, and put up a wall. So that's why I say, like, all right, what's low hanging fruit? What's the easiest thing? You already carry around a water bottle. Just track how much water you're actually drinking every day. Great. That's optimized. Let's move on to fiber. Let's move on to protein. So, and usually I start with protein first, honestly, but it's starting, I think, with those easier changes, because then you can give your brain the evidence that you can do this hard stuff. And it's much more likely to buy into, okay, now I'm going to go try lifting a heavier weight, or try lifting weights in the first place, or even just doing body weight exercises, or going for a walk with a weighted vest. You know, like sometimes it's just these little things that you have to get in for people and give them that confidence that's going to motivate them to continue doing the hard things.
Yeah. Yeah, it's just interesting to see like all the different pieces of the puzzle and how they fit together. So, the piece that's been really interesting to me is like, I've seen it with some progress that people have been making too, because we do have some people in the gym that have been on it. And, like one guy in particular, like when he started, like, I don't think he lost much weight in the beginning, and he wasn't on any of them, and he decided to go on them. And he's lost like 60 pounds now, and he's showing up to the gym regularly. He's in a better mood. I was talking to him the other day. He's like, I'm off my blood pressure medications. Like, I feel way better. And he wants to be at the gym now. Like, he shows up on days like he normally wouldn't before. And then he even like, he's asking more questions. He's just more inquisitive about like what's going on with other people in the gym, as far as like, oh, I want to do that movement. Like, that looks really difficult. Like, I want to get there, where before he'd like make jokes about like, you know, being the heavy out of shape guy or whatever. So it's really cool to see how it's flipped the script for him. And it might be one of these things that changes his lifestyle forever, because he's been able to make progress and sees the benefit to doing both. And, it's really cool to see how that can play out with someone. I guess my last big question here is too, of like, and I had one other case of a patient, and she had endometriosis actually, and some other health complications. And she was doing everything right, and she couldn't lose weight. And then she literally started on Ozempic or Wegovy, I forget which one. And just like, and she was overweight for sure. But she lost so much weight so rapidly. And I've talked to her multiple times, like, what did you do different? She's like, my diet is still the same. Like, I haven't even changed my eating habits. So who are the people that like, they're doing everything else besides like the menopausal type women? Because this girl was not at that age to be there. But what things, like, are there certain issues where it's like, this person's tried this, that, whatever, and they can't lose weight, and like, this is going to work for them? Are there those people out there?
Yeah, I mean, PCOS, we see that a lot. It's really not every woman with PCOS, which is polycystic ovarian syndrome, is overweight, but the sort of classic person is, and they often have pretty significant insulin resistance that goes with it. So it's not really just that your ovaries have a bunch of cysts, and actually you don't even have to have cysts on your ovaries to get that diagnosis. So I see a lot of success, and we, like I said earlier, we use Metformin for that too. So I do see that, you know, and I think I would think extrapolating that, you know, that's an insulin issue, and it's a hormonal issue. And I think one of those things that functional medicine is going to be really good at getting to the root cause, and maybe figuring out, is there toxin exposure? What else is going on? But I feel like anyone with sort of a chronic illness who tends towards chronic inflammation might, you know, and they're already doing all of these things. And I do see that a lot in my PCOS patients. They're really motivated because a lot of them have issues with fertility. So a lot of them are trying to lose weight, They want to be healthy for pregnancy. They want to be able to get pregnant on their own without having to go through IVF. And they're doing all of the right things. They're eating really clean. They are working out like crazy and doing all these things. And they're still just not able to make that budge. And so, for those patients, sometimes this is it. This just sort of takes them over the finish line. And then they're able to achieve pregnancy naturally, or things like that. So I think there's a place for it.
Yeah, I've heard Ozempic is making people more fertile or something too.
So here's the thing: if you're extremely obese, it can be very difficult to get pregnant. And so when you get into the right zone, it can kind of kickstart the whole system to make it work a little bit better. But on the flip side, if you're continuously deficient, then you can wind up with infertility issues as well, where it's really, especially if it's playing with your thyroid function, or you can get what's called hypothalamic amenorrhea. So you're not getting a period because you're just under-functioning, it maybe helps you get into the right zone. But again, like it's about doing the right things and utilizing it as a tool rather than, I don't know, just first line of like, I just gained 5 pounds on vacation. Let me do Ozempic for a couple of weeks. And, that's not what this is for. Or I'm going on vacation and I want to look good in a bikini. Like, that's not this. Like, this is not that thing. So, yeah.
100%. And so last question, what things should people know and be doing before they make the decision to go on a GLP-1?
I think you need to examine why and what could you be doing differently, and like what are your motivations, and really considering what potential side effects you could have that might impact your life, right? So fatigue is a big one that we see, nausea, vomiting, which if anyone has ever had morning sickness, they can tell you how awful that is to try to live your day and get through it when you're constantly nauseous. If you already have issues with constipation, this can definitely exacerbate it or can cause it in the first place. So I think what it is before you go on this is do your research. Talk to not just the people who have had really great success with it, but people who are like, that was not for me, and talk to clinicians and find someone who's really, like I said earlier, who's going to make sure that you're being safe. They should be doing some baseline labs, and that should include, a liver function tests and a complete blood count and checking your electrolytes, making sure that they check your pancreatic enzymes, getting a really good baseline, robust baseline, so that if something happens, we can immediately go and check and say, oh my gosh, no, that's elevated. We got to take you off of this, and that you're ready to put in the work. Like, yes, this is an easy fix, but long-term, it's not an easy fix if you're not doing the right things. So I think the right people who are going to go on this, or who it's best for, are the people who are just like, I have tried a lot of things. I'm really motivated. I want to walk my daughter down the aisle. I want to be able to play with my grandkids. I want to get pregnant. Who have these motivations that are not maybe just for vanity, although I think all of us have some of that in us, and that's understandable. But I think the people who are saying, I don't want the easy way out, I just need to get a jump start and someone to guide me through what I should be doing in a real way, not just listening to a podcast that says, eat this much protein a day, and do, someone who's there to guide them through every single step and help them find the rest of their team, whether that's dietitians, personal trainers, physical therapists, mental health therapists, really figuring out a team who's going to help them to make the most of this opportunity and thinking of it as an opportunity rather than, like I said, an easy fix.
Absolutely. Well, thank you so much for all of that information. Is there anything else about these drugs you'd like to add?
I think just be safe, be smart, and be ready to really make changes if that's, your motivation, I think. Yeah,
absolutely. And Laura, where can people find you?
So on Facebook and on Instagram, I'm at Sapphire Women's Healthcare. And then you can find me at my website, which is sapphirewomen'shealthcare.com.
Awesome. And she's right down the street from us in Westford, Mass. She's friends with our good friend Blair over there at Pregnancy and Postpartum PT. Yeah. So, yes, thank you for coming on. And it's been a pleasure to learn about these drugs. And if you guys have any questions for her as well and you want to message them through me, feel free to do so as well, and I'll get them over to her. So again, thanks for coming on, Laura.
Thanks for having me. It was great.
Awesome. Take care.
You too.
"84% of you that listen to this podcast frequently do not hit the follow button. If you've enjoyed any of these episodes, could you do us a favor and hit the follow button, leave a rating, and maybe leave us a review? It helps this channel more than you know, and the bigger the channel gets, the bigger the guests get. If you'd like to know more about training in person or online with Brett's Gym, Architect Fitness, please follow us on social at ARKITECT Fitness on Instagram, or visit ARKITECTfitness.com. Or if you want to rehab with Barbell Therapy online or in person, check out @barbell.therapy or visit barbelltherapyandperformance.com. Thank you for taking the time to listen.